Gainwell?
Nope.
Okay. Then I will skip down to, I think I saw Andrew. Jennifer is here. Brandon or Trevor? Anyone else from OHA?
Good morning, Dee. It's Michael,
Oh,
your
Michael.
community pharmacy liaison. It's nice to
Yes.
see you.
Hi, Dee.
Thank you.
Brandon's here.
Okay, thank you.
Thank you.
Hi, Dee. Good morning. Kelly, Brosel. I'm here.
Yeah. Yes.
Hi, Dee. Erin's here.
Thank you. All the guest speakers. And I saw Jason Gingrich too, I think.
Hi, everybody. Jason Gingrich, Director of Health Evidence Review Commission.
Thank you. And we'll be hearing from all those voices very soon. Anyone from industry, drug manufacturers, PBMs, that kind of thing? Okie dokie. Last call. Anyone else who needs to identify themselves, please?
Hey, Dee. Lucas Cootie with Align RX.
Thank you. All right. Okay, I think I saw some chat. Okay, I'm going to move on to pass it off to Mark for minutes review.
Thank you, Dee. Yes, good morning, everyone. Hopefully everybody had a chance to read the minutes from our August meeting that were attached to the calendar invite. Barring that, I guess we take a motion to approve the minutes, or if anyone has any corrections, speak up. Hearing silence, does anyone want to make a motion to approve them?
Motion to approve.
I second the motion.
Perfect. All those in favor of approving the minutes, say aye.
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 Any opposed? Okay, the minutes have been approved. So Dee, I will turn it back to you. Thank you.
All right, thank you. All right, so I'm going to move on to agency updates, and Helen. Thank you, Helen, for joining. So agency updates, the big one is I can now officially announce that we are waiving the new requirement for an annual third-party audit of PBM audit. I think there was Amber just reminded me that I'd announced before that I put the request in, there was a request made, but I couldn't say what the answer was. That is the answer, and we'll try to get that into writing fairly soon. But I know many are working on PBM contracts right now, and so that's a key piece of information, whether or not you need to do the audit. Any questions about that?
Dee, I just have a question. Is it waived for the upcoming year or forever? What's the time frame on the waiving?
not for forever.
Darn. Okay. All right. Just checking.
It's a new requirement. We're putting it in. We're not going to put it in and then waive it forever. So.
All right. Just checking.
So I guess it makes sense because the audit is supposed to be looking back on requirements, and those requirements by and large aren't starting until January 1 in 2025. So it would be unfair to you'd only be able to look back to January 1.
Couple months.
Yeah. So that's
all right. Just my wish list. Thank you, ma'am.
Yes, thank you.
And sorry, which audit are we talking about?
It's the annual. I think I think Array RX is already doing this, and this is for those who are not using OPDP. They need to do an annual third-party audit, PBM.
Gotcha. Thank you.
Sure. So that I will get that into writing because I know some reasonably folks need to have things in writing before they can really act on it. I can understand that. So I will do my best. I know that the team that sends out these kinds of memos have a lot of things that they're working on because there have been a lot of changes in the contract. So doing my best. The other thing you may have noticed is we have a new logo. Oh, I see a hand raised. Let me ask you first, Helen.
Oh, well, you may not be glad I'm here, but I want to be clear about what okay, it's waived. I got that. So it's not going to be looking back on 24. Are there guidelines for the audit? And maybe they're written and I haven't seen them, but I know there's a need for that audit, but are there specific parameters of the audit, domains that will be audited?
I can put the contract language. I happen to have that handy. There will be, try to put that in the chat. It's going to be really tiny, so I apologize for that. Hopefully you can, I don't know, open and expand it. So there's a little bit of information in the contract language itself. We will, when, later hopefully in 2025, have a guidance document, and whatever instructions that there may be, so that you'll have a better idea of what we're going to be looking for. Since we're waiving it for that first year, I haven't drafted what the guidance document will be yet. But I think the contract language gives you an idea of what kinds of things would be looked for.
Okay, I just wanted to be clear about what the parameters of the audit are, right? Because be well beyond what is articulated. I mean, they could be.
It could be.
Well beyond what is outlined in that small paragraph,
right?
Which I read previously. So I just want to. It seems like this contract would require it to be limited to the topics that are discussed in that, but there's some judgment there, I think. So that's why I was looking for the parameters and the domains that the audit will surround, basically.
Yeah.
And you may have some sort of template that you're already using with the OPDP contractor or contractors. And perhaps that's what you're going to do. I don't know, but the earlier we get that, the better, because the look back will be for the whole year, right? And we'll want to make sure that we're compliant. So do you have a target date for that?
I don't, what do you want to suggest one? I could I'd do my best to work toward it.
Well,
tomorrow is not going to work.
Yeah, fair or anything, but and I appreciate the waiver for this year, but I would hope we could get it, before the new year.
Okay. I don't know if I'll be able to do that, but I take note. I'm taking note that, this does, because it's not a report that you can just throw together. It has to look back over a period of time. And so you need to know what things to be working on during that period of time of the look back. So there are some things that have a due date of, say, July 1st that you can prepare in just 1 month. But other things that when they have a look back period, you need to have advance notice for that look back period. So I appreciate that.
Yeah. I mean, 11/1 would be still tight to make sure it's all in place by 12/1, depending on, exactly the domain being looked at. But I just want to, just call that out. And I thank you for your consideration on that.
Do my best. Okay. Thank you. I mean, I understand the concerns, so thank you for sharing that. All right. So the other less exciting, more exciting news is, you probably noticed we have a new the agency has a new logo, bright and colorful. You'll see it. There you go. Thank you for sharing that. So you'll be seeing that on most documents. That is maybe for a period of time anyway, a quick way to know if the document has been updated recently. So that's kind of something that I'm using. I will now, right on schedule, I think, unless there are other agency updates from anyone. Okay, I will pass it then over to Roger to do a P&T preview.
Thank you, Dee. Let me try to share my screen. Are you able to see our webpage?
Yes.
All right. As many of you are familiar, I hope you're already familiar. You've subscribed to our listserv. You'll get notifications of our meetings and minutes and newsletters and meeting information. So this is where we've posted the agenda and packet of materials for today's meeting, in addition to the written testimony that we received for several of the subjects. Couple things that we'll also post here. One of the topics we'll be discussing is a DERP report. Oregon is a member of DERP, the Drug Effectiveness Review Project. When they author reports, we summarize those. These are proprietary reports, but for a short period of time, we do post them around the meeting time. And this is also time as part of our consent agenda that we're presenting the CMS annual report and also the P&T annual report that'll later go to the legislature this fall. One final thing to look at here, the December meeting, we're going to be posting draft documents on October 14th. Just wanted to remind you all again, it's a great time for you all to look at what we're planning to present and to review that. If you have any feedback on our draft documents, we can entertain comments on those and actually edit those documents for about 2 weeks. So take a look at those, give us any feedback if something strikes your fancy or if however it might be treated in your own plan, because we really appreciate any input on those documents so that we have time to consider that with our authors and come out with the best reports when we post final documents. Once we post final documents, we're not supposed to change anything with 30 days before the P&T meeting. So go into today's meeting. Pretty straightforward, roll call and introductions. Pleased that we have appointed a new physician to fill out our whole role. So we've got 11 members now appointed. Well, then we have the part of our consent agenda. So you'll see again, those reports are part of that. Really, we don't take anything off the consent agenda unless the committee asks us to. So things that you'll see on these like literature scans, you can assume if it's on the consent agenda, there's really no new clinical information warranting us recommending a change. So we're primarily putting it here to do our due diligence for looking at the literature, but then intending to go into executive session to look at the pricing. So that's what we're doing with the Hep C, where no changes are planning to be recommended based on the clinical information. We are planning to retire our pegylated interferon PA criteria and then look at prices in exec session. As you're all probably aware with insulins, there's been a lot of dynamic changes since the first of the year and some pricing by manufacturers. So no new clinical information that wouldn't change our PL, but we are going to look at prices in executive session. And then our standing policies for oncology and orphan drugs. We add new agents to those standing policies, so it saves us a little time for doing reviews and being able to apply PA criteria when those drugs come to market. Let's see, then we've got the immunoglobulin drug use review. With that, we're not really planning any changes based on a review of the evidence. We are looking to implement PA for the non-preferred pharmacy claims for the immunoglobulins, just to make sure we're supporting off-label use and appropriate use. Then we'll look at pricing in executive session. Multiple sclerosis, that was that DERP report that was posted on our webpage. We've summarized that. The clinical recommendations are to maintain ublituximab as non-preferred and then add it and subject it to the PA criteria for injectable drugs. And then again, look at costs in executive session. We've got testosterone for hypogonadism. No changes there are we recommended based on the clinical evidence. Looking at prices in executive session, kind of a recurring theme. And inflammatory bowel disease. Again, no changes to the PDL are going to be recommended to the oral or rectal agents for IBD based on the evidence. We are clinically recommending that Tapiamlo, budesonide 4 milligram delayed release capsules and Eohilia are going to be subject to PA, and we're going to add them to the glucocorticoid class. Implement a PA criteria for budesonide oral suspension, and then look at cost in executive session. For Duchenne muscular dystrophy, update the PA criteria to incorporate the expanded indication for one of the agents, and actually for 2 of the agents. And then no changes to the PDL based on the comparative evidence, but look at pricing again in executive session. And finally, for the antacids, no changes based on the evidence. We will maintain venozaprine as dual therapy and combinations as non-preferred for the treatment of H. pylori, and make sure that it requires PA as part of our PPI PA criteria. And finally, not surprisingly, look at pricing in executive session. So with that, I'll entertain any questions. And as I outlined those recommendations, as you become more and more familiar with our reports, you'll see at the top of each of ours, just so I kind of familiarize you, at the top of each of the sections, when you look at this, over time, these have evolved. We have a plain language summary, the conclusions from the evidence, and right here at the top, you'll see those recommendations. And that's what I outlined for you. So it's really straightforward. You can already see those when you review our documents in advance. So just wanted to familiarize you with kind of the format that we present.
Thank you,
All right.
Roger. All right,
welcome.
then I will pass it on to Andrew then to review recent happenings in Mental Health Clinical Advisory Group.
Thank you. What we did this morning, well, what we've been working on the last few months is treatment guidance on post-traumatic stress disorder and touching on basic assessment and outlining great resources available to providers for assessment and trauma-informed care and different screening tools and then outlining best available evidence for treatment of PTSD and co-occurring disorders that are common, like sleep disturbances and primarily nightmares, but also substance use disorders and bipolar disorder and other common conditions. And so we'll probably finalize that draft next month. We meet every month right before this meeting, first Thursday of every month. And then we also discussed this morning some legislative ideas for our legislative report for the 2025 session as it relates to mental health treatments in Oregon and workforce capacity, acuity, high acuity, and intermediate acuity beds, as well as some other topics related to maternal mental health care. And so, in terms of pharmacy, there's obviously with PTSD, there's no drugs that are groundbreaking over the last several years. So we're talking about old generic medications that have been used a long time, and just really focusing on how to better appropriately use them and when to use them. But as with many other mental health conditions that focus on psychotherapy, and there's a lot of trauma focused cognitive behavioral therapy that has a lot of great data for effectiveness. And we know that those types of psychotherapies are much safer and have longer impact in helping these people that suffer from this. So that is a quick summary. Any questions or comments? Everyone is always welcome to join us if you wish. Public.
Yes, thank you. I think we recently got some recognition from someone in another state, I think, about using the work of the Mental Health Clinical Advisory Group.
Yesterday, got an email. Someone from California wanted to use our resources for the benzodiazepine taper. Seems to be pretty popular, and I don't know if the CCOs have seen that document, but it seems to be appreciated by a lot of different people around the country, using that document to help taper people off of benzodiazepines, with an emphasis on individualized tapers over an extended period of time for greater success.
Is that something you mind sharing with this group? I can't recall if I've seen it or not, but it seems
absolutely
awesome.
would love to share it. Yeah.
Thanks, Andrew.
Mental Health Clinical Advisory Group is obviously online. If you just type that in, it's their homepage, and then the recommendations are on the right. A link to all of our recommendations, but I will put that link right here in the chat.
Oh, thank you. I get lost, I admit.
Well, yeah, our web pages are just the most organized, aren't they?
Thank you so
know.
much. That's awesome. Congrats on getting recognized.
Yes, lots of good information there. And if anyone has would like to delve into any of these topics or have a kind of a roadshow, I guess, of a longer presentation of the Mental Health Clinical Advisory Group, we could always do that for a future meeting.
Happy to share PowerPoint slides of our documents when we approve them if anyone's interested in more clinical information. And also, again, you're welcome to explore our website and come to our meetings and share any ideas for future topics.
Yeah, thank you. All right, so that has been Andrew put a link in the chat. So some of you may be busily looking at that. That's great. I think we are a little ahead of schedule, but it looks like Jason's here. Are you going to be joined by anyone else from Leah or anyone else?
Unfortunately, Leah had a situation and is not
Oh.
able to join us today, so it's
Okay.
me.
Okay.
And if I can't answer anything, I will just take it back and we'll get back to people. But as I said, I'm Jason Gingrich. I'm the director of the Health Evidence Review Commission. I am not a clinician. I use he, him pronouns, and I am also working with others here at OHA on the benefit update project. And today I want to give an update to you all on the impact of this project, especially on pharmacy. I'm going to go broad so you have context, but I'll try to spend a little extra in energy on the most relevant part to those of you on the pharmacy team. So first, kind of start with the bottom line up front. So Oregon has a 1115 waiver, as many of you know, that allows us to use the prioritized list to manage the benefit. That waiver agreement with the federal government will end beginning January 1, 2027. That will not be in place. Just as other states do, we will be using, after that date, our state plan, our medical necessity policy, utilization management to manage our OHP benefit. The state plan will define high benefits at a high level, very much as it does today. We don't expect a lot of changes to the state plan. HERC and the OARs will provide medical necessity policy and, of course, the PAT criteria, much as they do today. Of course, the references to the prioritized list will need to change. Other criteria will come from CCOs, again, very much as they do today. Medically necessary state plan services must be covered. And that is changing because there are some limits in the prioritized list that now kind of override the state plan. And so that's going to be a change. Some services will still not be covered. So this is not mean everything that is ordered by a provider will be covered by OHP. There will still be some limits, and I'll go into the rules about those soon. We expect a relatively small increase in the scope of services, and some of that will be pharmacy. So again, CMS ended Oregon's waiver, and that is in effect January 1 of 2027. So we've got some time here. Although the structure is transitioning, operational elements of the prioritized list structure will continue. We want to smooth the transition for our IT systems, our CCO partners, people who are familiar with the list, preserve the best of what we've been doing, but make sure we comply with the new requirements. So the HERC evidence review, the HERC code pairings, those of you outside the pharmacy realm will be more familiar with those. HERC medical necessity guidance in the form of guideline notes, those were all expected to continue. HERC's public process will continue as it has for many years. Going to take a little dive here into federal Medicaid requirements to help understand what we're required to do with this. So each state, as I said, has a state plan. It's our agreement with the federal government. It organizes benefits into high-level categories like physician services, lab and x-ray services, and so forth. It also defines some high-level limitations on both mandatory and optional services. And when I say high level, I mean, instead of the 100 or more pages of the prioritized list, you have, a page or so on a benefit like physician services, and it says some services may be subject to prior authorization, and it doesn't say which ones. So it's very, very high level. Of course, there's a section on prescription medication. Again, we don't expect a lot of changes there. There are two key federal rules for benefits that apply. The first one is the one that's currently waived, and it says that the state may not arbitrarily deny or reduce the amount, duration, or scope of a required service because of the diagnosis, type of illness, or condition. That's waived now. Now, I've worked with HERC for many years. I may not view HERC's decisions as arbitrary, but I know, in a legal sense, this is what is waived. That waiver is going away. But this statute will be in place, and so that will constrain OHA in ways that haven't been true, or aren't true today. The next subparagraph there says the state may place appropriate limits on a service based on such criteria as medical necessity or on utilization control procedures. And that is the work that you all as pharmacy directors, that our P&T team on the fee-for-service side do every day. That work can continue with a couple of tweaks, which I'll get into. Again, our current waiver, there's a direct quote. I won't read it, but that's what's going away. What that means is after January 1, we can't prioritize or deprioritize services in the form of a list. We can continue to place limits based on medical necessity and can manage utilization. HERC will continue to determine which OHP services are medically necessary and provide medical necessity criteria and policy for some services. Now, I will say, because we're talking to pharmacy directors here, we expect less HERC guideline notes to apply to pharmacy services, because in many cases, the function of those HERC prioritized list mentions of pharmaceutical products, are referring to the funding line, which since we won't have a prioritized list, there won't be that anymore. However, CCOs can continue to manage the benefit subject to the state plan, medical necessity, and CCO contracts. Here are the mandatory and optional categories under federal law. These are just some of them. There's a full list in the link there. I think this presentation will be distributed after. You can see their prescription drugs are optional. However, as I'm sure you all know, there is also federal rebate law, and Oregon participates in the federal prescription drug rebate program, about which others here know much more than I do. But essentially that it makes it an all or nothing. It constrains the state's ability to put limits on prescription medications that are FDA indicated or compatible with compendia. So there's going to be some change. There's also going to be some continuity. So the legislative funding line. So, often there's talk that HERC decides what to cover and not cover on the prioritized list. In reality, the HERC makes the list. The legislature determines the funding line, although that's been frozen since 2012 by agreement with CMS. That funding line will go away. And without a funding line, there's really no need to rank one service over another. So all services, all conditions, will need to be addressed in a similar fashion. And that's somewhat true today, with services on line 469 are covered in exactly the same way as services on line 1. What's different will be that unfunded region will go away. Any denials that USCCO pharmacy, that your systems generate or that your staff communicates that reference the funding line or the prioritized list, those will need to be changed or eliminated in some cases. And we'll get into that a little bit more. There will be no more need for the comorbidity rule because that references the funding line. Now, there may be some other changes related to that. More to come on that another day. There will be some continued processes, coverage decisions and denials that will be based on medical necessity and benefit limits. Code pairings, guideline notes will continue to support medical necessity decisions, and I'll add their, prior authorization criteria that you use today. HERC's public, transparent, evidence-based process for decisions about medical necessity will continue very much as it is today, and I think the same is true for our fee-for-service pharmacy and therapeutics committee. What is happening? What additional service? The unfunded region is going away. What's going to change? What additional services will cover it? How much will that cost? Obviously, an issue for anxiety for plans, also for the governor's office and the legislature. How much is this going to cost? We are in the process of doing that review. We don't have an answer to that. However, what we do know is there are a lot of conditions below the funding line that only need office visits, medication, and in many cases, they're low-cost generics, emergency services, and no change will be needed. From a HERC perspective, I should say that there may need to be some prior authorization criteria developed for those medications in some cases. Some below the line conditions already have guideline notes, and those may just be converted into medical necessity policy. Others will require some analysis. Why did HERC place it on that line? Is it because it's not medically necessary? Is there sufficient evidence that it's medically necessary? Is it safe and appropriate for patients? HERC will be doing that work, although again, largely not about prescription drugs. For prescription drugs, and this is bold, any criteria in your PA, again, related to unfunded conditions, the funding line, prioritized list, or categories excluded by the funding line will need to be reviewed and often replaced with medical necessity criteria. And I'll just give an example there of one that is low cost but potentially relevant. Lyrica and gabapentin have indications, I believe, for fibromyalgia. That is an unfunded condition as of today, and CCOs could be denying those, not because they're not medically necessary, but because of the funding line. In the future, there may need to be some criteria around, when those are covered and when those are not. And that's just one example, of course. We do expect a budget impact. Rates will be actuarially sound. We'll follow the usual rate-making process. Again, I'm not the expert on that. I just know that we're going to need to be doing that, and we're doing the analysis related to that on our team. So there will be no formal change in HERC's authority to review medications. In other words, currently HERC doesn't have the authority to review, do drug class reviews. There still could be a HERC guideline that references medication, but based on our analysis to date, we don't think there will be some of those decisions we think can just be made by our Pharmacy and Therapeutics Committee for fee-for-service, and then it will apply to CCOs in the way those do today. Some medications that are currently denied, again, based on the funding level, will become covered, though clinical prior authorization criteria may be applied to ensure appropriate use. So this is basically, the way you do it for conditions that are in the funded region today. There'll be the similar ability to do prior authorization criteria. References to that funding line in clinical PA criteria will need to be removed again. And I think there are some classes as well that don't have any conditions in the funded region, and so maybe, and I don't know the technical term here, just not covered. Those might need to be reviewed and criteria considered. Our work plan for our team at HERC is January this year, 2024. We've been doing a lot of staff planning and analysis. It's been a big part of our work. It's been behind the scenes, just to understand what's going on, what the implications are. We're looking at the below-the-line services for medical necessity. We're meeting with experts in various specialties. looking for opportunities to simplify things where we can without sacrificing important detail, trying to ensure that we're centering equity in all this process. Next year, although we may actually get an early start on at least one topic, we'll start to have public meetings where these things will be discussed. So what will be the medical necessity criteria for fibromyalgia and many other conditions? Refinement, budgeting, and incorporating changes made to the prioritized list into what will now be called code pairing files and medical necessity policies. And those code pairing files will have the same structure as the prioritized list does today. They just won't be prioritized because that won't be necessary. Here's the fee-for-service pharmacy preparations. 2025, there'll be staff analysis and planning. Be looking through those PA criteria, evaluating utilization of common medications. 2025 and 2026, there will be evidence reviews, make those criteria. There will be drug use evaluations to evaluate medically appropriate utilization and collaboration with stakeholders, including all of you and our Health Evidence Review Commission. After 2027, of course, there will be ongoing evaluation of drug trends, PA changes, and the impact of those. So this may be something you may want to think about as you plan for this transition at the CCOs. I'll give brief attention to this side, but this kind of talks about that change to the code pairing groups or what's now the prioritized list, how that policy will go. The key thing there is that green unfunded region. You'll see that's not present on the left side, and it's split into two things. Some things that will become code pairings that will be medically necessary, and some of those will have policy associated with them in the form of guidelines. Others will just be non-covered. They will not be included in the state plan. They will not be medically necessary. That will continue much in the way that it does today. But the HERC's decision will be, splitting those out. We'll also be, as I said earlier, simplifying. There's 469 lines. If we're not prioritizing, we may not need that many lines to represent the coverage policy. It may reduce errors and simplify things to combine some of those. For example, lots of conditions that only require basic office visits or have similar sets of treatment. If there's opportunities to consolidate those, we'll look at that. There are services that may not need prioritization or utilization management. And again, we just may simplify things there. HERC's decisions, we expect a very similar process to what we have today. We may rename one of our subcommittees to better reflect its new role, but the work will be largely the same except for the prioritization part. This is the timeline for the overall project. Busy slide. I won't go through all of it, but you can see, the HERC meetings starting probably late this year, possibly early next year. And I guess P&T is not on here. They should be, but we went into detail about that earlier. There are also opportunities for interaction. There's going to be a work group with CCOs, and we'll have interaction as needed about pharmacy topics, I'm sure. There's also, as you see, a legislative concept to be developed because HERC's deliverables will need to change at a minimum. So that analysis is ongoing. It'll be shared when it's ready. We will continue to provide updates through another meeting in November with the CCOs and open card contractors to share information. We've already had 2 of those meetings in August and September. There will be a work group for CCOs starting up in late fall to do more technical nuts and bolts issues once we've got the big picture communicated. And then we're also anticipating a public meeting in the fall. And there will be updates continually at the QHOC group and the HERC public meetings. If you have questions or comments we can't address today, please email us That email below, 1115waiver.renewal@odhsoha.oregon.gov, is there for your questions. We do our best to get through those and get back to you. They may inform our work. They may cause us to refine our work. So really appreciate those questions. The more good constructive questions we have, the better we'll be able to work with our partners, including all of you. There's also a web page. I'm not going to try to read that link, but you all can click on it when you receive it. And that will, you can also Google OHP Benefit Update Project and you'll get it. At least I did. And stay up to date on the latest information there. So that's all my presentation. Have a few minutes for questions here, I believe.
Yes, there can be questions on that. I already have one hand up. I was also hoping that Roger or Sarah could talk about how you've incorporated and planned for the P&T for pharmacy changes in the fee-for-service program.
No, we can't.
Okay.
No,
Sorry, Katie, you're gonna have to put your hand back up.
Well, clearly, I mean, we're aware that this is going on. And like we've done with some classes, so you think about things like psoriasis or mild to moderate. One of the ways you look at where your utilization might occur is looking for the therapies that you wish to make available, perhaps without prior authorization. So another class might be constipation. So we have step therapy requiring, 2-week trials of certain agents, dietary modification, bulk forming laxatives, for example. So thinking about classes where you might be opening up unfunded conditions and providing therapies without restriction so that members have access is one strategy that we've been encompassing. And looking at that going forward as we have classes that are in the unfunded region, how do we want to address those? So we can still make sure that they're medically appropriate and medically necessary. And so, you can have PA criteria to make sure that that is a good resource to make available and make sure that the provider, sometimes watchful waiting is a better choice, right, than treating something, as we all are aware, like with antibiotics, when you probably the cold will resolve over a few days. So that's one strategy. And then also, for example, Jason was mentioning fibromyalgia. So you might be opening up access to certain medications. So looking at your criteria and making sure that the medication is working. So, how long of a trial of a medication do you give? What's your expectations for benefit from that therapy? So that can be rolled into your PA criteria. So to Dee's point, what we've done so far, we've kind of already started cutting our teeth on this because of EPSDT. So previously where we might have been asking, is this a funded condition? No, deny. We knew that for members less than 21 years of age, had to have a pathway for coverage under EPSDT for unfunded conditions. So that's really the first step of us looking at those questions where we asked, is it funded? No. We've added that layer to say, well, what's their age? And then start to work in that, is it medically appropriate, medically necessary? That will continue to expand with YSHCN, Yishin, I don't know how you pronounce it, D.
Well, we will have the experts tell us in our next presentation.
Perfect. Segue to that. So we'll be looking at that. And again, it's going to be an iterative process looking at this. And as Jason mentioned, collaborating with you. I mean, you'll be looking at your own benefit and where you start to expect to see the need to open coverage, therapies and classes that might be expensive. I think there's going to be an opportunity for us to have a standing place where we can start to collaborate and talk about classes that we are starting to move in that direction. And strategies that others might not have considered, or maybe provider practices in certain areas. I think about allergists or non-sedating antihistamines. So there's just classes and places of therapy that I think we need to work together. And again, we need to have a pathway to coverage. I think from a coding perspective, most of you have probably coded drugs, even if it was for an unfunded condition, as PA required, because you had to have the ability to consider the comorbidity rule. So it's kind of a process of looking at your coding, looking at your medications, and then looking at your criteria, and then considering the costs of those therapies. And I think a really important strategy is to make certain therapies and first-line treatments available with limited or no restrictions if possible. So that's kind of it in a nutshell in a scattershot approach.
Okay, Katie, you have your hand back up, so I will turn
I
it to
just
you.
want to, first of all, say thank you, Jason, for preparing these slides and going through them in this forum. For me, this is my first really opportunity to hear from others about this change. So thank you so much. And Roger, I really appreciate hearing from you, like how PNT looks to kind of deal with this. And Dee, thanks for putting time on the calendar. I think this is such a really great forum to have these conversations. And I would love if this maybe is a standing item, because I think this is a big change. I know hearing yesterday at the CCO Oregon conference from Emma at OHA, and even, you know, as these conversations progress, that it's not really a big change in pharmacy. I think about just all the little downstream process changes that need to occur. And so in my mind, you know, it is a big change just for those who touch these reviews. And this happens in 2027, which sounds so far away. But I think about all the internal, I mean, I know you know it's not, but all the internal people in our processes that have to be updated, our policies and procedures, because we do so much that's based on the covered line. There's so many conditions that have to be touched and worked through before 2027, that we need to decide if we want to have a prior authorization. And so I think working together on that is going to be really important. I also get concerned as a clinician when we talk about medical necessity, because I know that we can define it and we can have criteria around it, but that's just always an arguable concept, especially when you're talking with a provider. And seeing, you know, even in the commercial space too, this concept being flipped on appeal, or IRO siding with the prescriber. It's just a, you know, it's a more gray area, which I think might be the reason why these decisions are based on medical necessity and not a black and white funded condition. But that just makes me then think about, are we going to have increased coverage? What does that do to the funding? And I think, you know, these are all areas that everyone's hopefully thinking about downstream. So just wanting to say that out loud to keep in mind. So again, appreciate that, and would love for us to kind of continue to visit this as we're updating processes and kind of working out how do we really keep control, not just of costs, but of you know, good care that's cohesive. So.
And before we go on to the next question, I guess along those lines, when you have your own denials internally, I would suggest look and see if you have a reason code that's being denied for an unfunded. So
we
for that
totally
particular,
do.
right?
Yeah.
That allows you to pull reports so you can start looking, where's the classes, what drugs,
Right.
what might happen in this space. So it lets you start to get a picture of what that is. And those are the kinds of things we can share and then strategize around appropriate use.
And then if we add more prior authorizations, I just also consider the time involved to review prior authorizations and what that does to our turnaround times and things like that. So thank you.
Thus, the strategy of having a lot of first-line affordable medications available with step therapy explicitly saying, try these, and that might cut down on some of those PAs as well.
Totally. But then we have so many people who want the branded ones.
All right. Thank you, Katie. Helen.
Hi, good morning, everybody, and thank you. It was the two presentations were really excellent and really helpful. So I agree with Katie that we really need to be bringing this back on some regular basis to keep tabs on it as this emerges, so that you know, so that at the end of the day we really have still good products and good experience for our Medicaid members, right? It's they're our most vulnerable. They don't, you know, they have different literacy rates and multiple languages. It's just all of those issues contribute. And I know you all know that. But what I would Norm, who is always on the call here for Providence, and one of the great people that I work with at Providence, he's getting my hot texts about, okay, there's some things we need to change and we need to pull in our formulary and P&T people and really, um, you know, initiate some of this work. Because like Katie, this is the first time I'm hearing it all in a cohesive manner, really. And it is not a simple change. So whoever is saying it's a simple change in public, or we've got to change the storyline with our executives on this topic. It is not a small change, and it could have significant impact on pharmacy budgets if not handled correctly. But it is going to take additional administrative expense, right, to do that, and we know that. So totally agree, and I'm aligned with kind of the initial approaches that you're talking about doing. But we use that line, that denial code is common for unfunded conditions, and it's really treated like an exclusion, right? An exclusion of coverage, which may not be a great member experience um, or physician experience, but it does help manage the Medicaid budget, which is so limited, which is that brings me to really a second, my question. I know, Dee, this meeting is recorded. Is there any chance we can get the recording for our like our P&T people?
I will check on that. I think,
Okay.
yeah, I'll check on it to see if we can do that.
Or set up, at least for those that don't use the OPDP approach, at least set up a forum that we could have bring our P&T leaders and P&T people to hear the same message we just heard from
Mhm.
Roger. And I'm sorry, who was the
Jason.
presenter? I didn't. Jason.
Jason,
Yeah, Jason.
yes.
Thank you.
Yeah,
Sorry,
hey,
Jason.
I will, should mention too, I'll be giving much the same presentation without some of the pharmacy details at our HERC and VBBS meetings next Thursday, October 10th. And that will be posted on our website afterwards. So at least at a minimum, that will be available. And people could come to that to attend if they want.
All right. Okay.
We won't have as much interaction there, but yeah.
Okay, thank you. That's helpful. But I do think that it would be good to get this specifically in front of the pharmacy leaders so that we can really get going on the changes and our medical directors that support the pharmacy program. So if that's something that either we could do by some sort of recording, or if there's a way to, you know, Roger, have you and Jason come to a meeting that we could schedule like that with the CCOs. I know the health share part of the organization. I think there's a lot of those members that are covered, through there's the P&T at Care Oregon, and I'm not intending to speak for them, and the P&T at Providence. I think that'd be helpful. And the P&T, which is the P&T at Providence that supports YCCO. I think I think that would be helpful. So just a suggestion and a question really kind of rolled into one. And then the other thing you mentioned, it will be actuarially equivalent. The question I have in my mind is, are the actuaries that are going to be used expert in Medicaid drug costs and issues with the below the line? Do they understand how much is in the below the line and what will be their comparators for that? It's going to have to be outside the state of Oregon. We've been doing this below the line thing for 30 years. Almost, I think. Long time. So I just wonder how, I know the intention is to build it actuarially equivalent, but I think, I think that's
I hear
something
the
that
anxiety. I hear your anxiety. I think maybe talking to your actuarial, your budget team, maybe they could give you some guidance too on what they've heard and what they know.
Yeah.
I mean, all I can say is we have very, very, very knowledgeable, highly skilled experts in OHA and our actuarial team. And I know that they consult with an outside group as
Yeah,
well
there's
for,
with an
yeah, so
outside group.
yes,
So it's internal plus outside consultation, and there may be some um, actuarial discussions with the public. Are there? I mean, do they talk about that at all when they're working on that? I
I
I'll
can't
talk
really
to our
speak.
actuary.
Yeah, because I can't
Yeah,
speak
I
to
gotcha.
exactly. Yeah.
I
And I
gotcha.
mean,
But
it's also because this is all about, you know, state plan and waiver and,
yeah,
the
yeah,
CCO, we still
I
have a
got it.
CCO waiver, like CMS is watching it and we have to prove to them that things are actuarial sound and there's standards and, all sorts of
All of
things.
that.
So, yeah.
Okay, I'll at least consult with our actuaries and make sure that they're aware of this issue as well. Um,
Yeah.
just, because Medicaid does continue to be an underfunded program and
Sure.
it's very hard to maintain
Sure.
for all of us.
And
So I know
if it
that
would
everybody's
help,
doing the best they can. Yeah.
yes. And I hear the anxiety. We do, I mean, I can tell you that we've had lots of conversations with our actuarial team trying to identify which drugs might be the most costly or not necessarily individually, but in over the course of a year. So we are trying to identify those things and share it back with the actuarial team. If you have something in particular that you think, oh, have you thought about this? Feel free to send it to us and we'll look at it.
Okay.
You
Yeah.
know?
Okay. Yeah. No, and I'll check with some of our leaders in the actuarial areas where well as the program overall. But I do think that as pharmacists, we know the drugs very well, and the actuaries do rely on us to provide them good information. And
Mhm.
so I think that it's it's an
Yeah.
intentional sport to get actuaries involved in the work. And I think it's hard to know what utilization would be of all of
Yep.
these things had it
Right.
not been for the
Mhm.
below the line. And
Yes,
the only way to compare it is to look at something outside of Oregon, right?
Yes.
So,
I understand that. Yeah, I'll have to move on to some other folks, but I
yeah,
appreciate,
I
yeah,
gotcha.
it's
I
true.
gotcha.
I hear what you're
Yeah.
saying. And Dr. Carr in the chat asked, is OHA implying that this will not increase RX costs significantly? I don't think we're saying anything to that effect. Jason, do you have? No. Um, we're not assuming that this
There
will
will be a
be,
budget increase.
yeah.
We're not prepared to give any details today.
Thank you, Jason. Tiffany. Oh,
Sorry, forgot to come off of mute.
okay.
Just a plug for pharmacists in the profession everywhere. And that we would love to be a resource for you guys because pharmacists do a lot more than we do drugs everywhere, and drugs happen to be everywhere. So a lot of the pairings and the costs and everything, I know a good portion of all of our CCOs are also actually managing a lot of the medical codes as well. So we can definitely give you comprehensive lists of things like that. A lot of the drugs being given in outpatient settings and things like that. We would love to be a resource on the totality of treatments for conditions when, whether it's the inpatient as it shifts to outpatient and then a lot of times to the chronic conditions. But a lot of our teams do that as well. And so just to be a resource to you guys and not be surprised when those numbers are also coming from pharmacy to our actuarial teams.
Mm-hmm. All right.
Just
Thank you,
plug for all
Tiffany.
pharmacists. We do a lot.
Yes, you do. And that's great. Thank you so much. And Rhea, I think will be our last one before we move on to the next topic.
Thank you, Dee. Just a really quick question. I have an internal P&T meeting next week, and I wanted to ask Jason's permission if I'm allowed to share the summary slide with the timeline that you had with our P&T committee. I don't know if that information can be shared or not.
I think if we're sharing it publicly, I don't think we can expect it to be secret from anyone.
Okay. All right. Thank you very much. I appreciate that.
Appreciate the
You know, again,
question.
to the previous comment, we want feedback if there are specific medications, specific physical health services that you think need scrutiny or review. Please use that email address. We're here with it. That's going to help us help you.
Wonderful. Thank you so much. So I'm glad we started that early. Unfortunately, that might have meant that some people that tried to join the meeting specifically for this didn't catch the first part. So I will see if there's something we can do to share more of those details. I will, I think, move on to the next presentation. But I'm not sure if Max is here. Max, are you here? Oh, thank you, Jason. I understand you need to go.
Yes, I'm here.
Oh, wonderful. Terrific. Okay, Max. I'm going to pass it on to you to talk about EPSDT, the extension for young adults with special health care needs. I think that's usually the acronym of YS, or I can't remember initialism. YSHN. Yeah, YSHCN. I will pass it on to you. Thank you.
Thank you, thank you, thank you. I will say more about it, and hopefully by the time I'm done, you're able to say Whiten. It was a mouthful when I started learning what it was, and it still is for me as well as a whole lot of folks. Hi, everyone, and thank you for welcoming me in this space. I am here to introduce this group. So I've met with Medicaid medical directors and now meeting with the pharmacy group to introduce this program, which is a Medicaid benefit and new eligibility category for what we designate as young adults with special healthcare needs. I may end up saying WISHN from this point on because it's a mouthful. I'll talk about what it is. I'll introduce myself briefly and take questions from you towards the end. So what is WISHN? It's a new Medicaid eligibility category that goes into effect on January 1st, 2025. And essentially OHP benefits will be extended to folks who are considered young adults, so within a specific age category, under certain qualifying conditions. So I'll say more about it in just a little bit. So I'll do an overview of the Oregon 1115 Medicaid waiver. You may know quite a bit about it, so it'll just be a brief overview, talk about the program, talk about the intersection with EPSDT and HRSN, mouthful acronym. Some of you may know what it is, but I can talk about it a little bit more, and then give more details before I take questions from you. And before I start, I'm Max Tervenencourt, pronounce he, him. I am the policy lead for this particular program at Medicaid, among other things. So I am leading the implementation of this program, which means making operational in our system. So both on the eligibility side with one, on the MMI side with claims that will come starting in January, as well as making sure that in rules and policy, we have all set up to start administering this benefit. So I'll do a detour and talk about the 1115 Medicaid waiver as a backdrop to this work. So obviously, Medicaid administers the Oregon Health Plan, and it provides free health coverage for folks who live on a low income, folks, who are children, teens, and adults who live in Oregon within a certain income bracket. So the 1115 waiver, as all waivers do, basically help the state petition the federal government to make certain changes to the way some of our programs are administered, and in our case, to extend OHP eligibility to young adults with certain qualifying conditions. So the 1115 waiver, obviously the intent is to extend OHP benefits as well as continuous eligibility to folks who are children, so children up to the age of 6, youth, And very importantly, are the second to last bullet, young adults with special healthcare needs up to the age of 26. The way I like to think about Waishin is that we're actually providing a bridge period when folks get to transition from pediatric level of care when they're under the age of 19 to that Waishin coverage before they would get adult level coverage after the age of 26. And coverage is limited for folks in certain settings, like folks in carceral settings, and we're still determining how this works with the foster care system as well. So there's still some policy work to be done, but overall, we're ready to launch and implement this program. So who qualifies for Waishin starting in January? So the whole category is folks who are 19 through 25, although next year we will only be starting implementation for 19 and 20-year-olds, and hopefully I can say more about it later. If so, young adults 19 through 25 who live.
Uh-oh. Is Max frozen for everyone?
I lost
Yes.
audio.
Yeah, me too.
Okay. Oh no. Thanks, Jessica, for noting that.
No problem.
Well, oh, very confused, Max. I'm sorry. Technical difficulties are a problem. How can we help?
Oh, okay. I don't know. I was presenting until I realized you weren't following me. Are you able to see my screen?
Yes.
And are you able to hear me?
Yes.
Okay. I'll keep moving forward, and I hope this is all of it. So, we're talking about young adults, 19 through 25, who live with one of these three conditions. So, a physical, intellectual, or developmental disability, a long-standing medical condition, or a mental health condition, substance use, or neurodevelopmental condition. They would qualify under this program. Why is it important? Well, because in Oregon, 1 in 5 children under the age of 18 has a special healthcare need. And I like to say, they become young adults with the same needs. And we would want to be able to support their health coverage through young adulthood. They also have more health and social services needs than other folks the same age. And the waiver really gives extra time to provide coverage for folks who are transitioning from pediatric to adult level coverage. So what changes in January? So currently, folks in that age bracket would only get OHP with this level of coverage. If they lived up to 138% of the federal poverty level, they would get early and periodic screening, diagnostic, and treatment, as well as vision and dental benefits that would end at 21. Next year, that allowable income goes up to 305% of the federal poverty level, and EPSDT that I just mentioned, vision and dental benefits, would end at 26. I'll just pause here. And I can send this presentation to you afterward if you would like
Yes,
to
please.
review it. Awesome. EPSDT and HRSN. So EPSDT, sorry, federally required benefits. So I just spoke the acronym Early and Periodic Screening, Diagnostic, and Treatment. Federally required, which is a way to say that we provide complete health services for children and youth. So it used to be under the age of 21, independent of the prioritized list, and Waishin will be included. So EPSDT will be extended for folks who are Waishin through age 26. And this is what's reflected here. So starting in 2025, EPSDT coverage based on medical necessity and appropriateness goes through through 25, so would end at 26 instead of ending at 21 the way it does today. And just a reminder, EPSDT care is based on medical necessity, so what someone needs to support their growth, prevent diseases, treat conditions, and medical appropriateness, which means is it safe and is it effective? And I have an example here, but it could mean receiving drugs for behavioral health treatment or other condition in the context of pharmacy. Why should also get HRSN health-related social needs benefits as long as they qualify for our program. And this encompasses housing support, so think rental assistance, nutrition support, think SNAP, climate support, think air conditioning units for folks who can't afford it when it's extremely hot outside, and some level of outreach and engagement, which includes this sort of dialogue, but for external partners as well. And just speaking to it, it's, our engagement strategy involves providing culturally and linguistically appropriate communications, making sure that we communicate with the right folks and our community partners, application assisters, uh, medical providers, and pharmacy providers in this case as well, to make sure that they know what WISHIN is and how we can collaborate to ensure that folks who are entitled to this benefit get access to it. So what it means for community members, so next year, starting January 1st, 2025, 19 and 20-year-olds will be able to enroll, and they would keep their WISHIN eligibility until they turn 26. And their eligibility is reassessed every 2 years, so they have 2 years of continuous coverage without needing to reattest to their eligibility for this program. Practically, what it means is up to 8,000 potential newly eligible individuals will be able to get OHP because of WISHIN as a program. Over 16,000 current OHP members will get additional benefits based on the age requirements, the income requirements, and the condition requirements. A lot of folks will meet the pathway through having an intellectual or developmental disability, and continuous coverage, like I mentioned, is for 2 years before folks are reassessed. So we just want to make sure that you know about this and that you can use this information or relay this information when and where it is needed. So just to give you an idea how we identify WISHIN, obviously we will go with the criteria that I previously mentioned. So in 2025, someone would need to be 19 or 20, live under 305% of the federal poverty level, and meet one of the 4 criteria listed. So if they live with one or more complex chronic medical condition through assessed through the pediatric medical complexity algorithm, or they have a mental health condition on an approved list of disorders, or they're referred to us through ODDS, or they fill out a screener if they're a new OHP applicant through the ONE system. And that screener has been developed with the Oregon Center for Children and Youth with Special Health Needs, also known as OCEAN, and this will be fully integrated within the ONE system for new OHP applicants next year. For existing OHP applicants who qualify, the ONE system will evaluate them automatically and they will be enrolled as long as they meet the qualifying criteria. I just mentioned OCEAN. The partnership, oh, very importantly, the screener is available in 6 languages. Very important, especially for folks who do not have English as a first language. Yeah, just welcoming your questions, your thoughts. Sorry for the audio glitches. I hope you were able to hear me. Otherwise, happy to provide more information on this program. I will stop sharing so I can see you when you're asking questions. I'm also very happy to send this presentation for folks who want to refer to it if you need more information.
Yes, thanks, Max. If you get it to me, I will get it to everyone else. So I appreciate that. I think when we've been discussing in the pharmacy team at OHA, we have seen EPSDT as the part of this WISHN program that will be most requires most of our attention. And one of the things that came up is, well, how will we identify them? I don't know if you have anything that's available that we can share now with that CCOs, have they been told how they would identify these members?
Yeah, so very importantly, just yesterday we issued what is called our WISHN CCO guidance document to all the CCOs, which lists things like what the program is, how WISHN members are identified, and very, very importantly, I know CCOs are really anxious to have this information, the perks related to WISHN. So there's that. I know that there's still, we still need to develop a process once someone is deemed potentially eligible to have them processed and enrolled. Our guidance to CCOs is to communicate with their reps. And I think they have a contact information listed in our guidance document. And for open card providers, we will be also issuing a guidance document that is not available yet, but will be issued very quickly before January.
The document, the guidance document you were just referencing, is it available? Is it posted publicly?
It is
Can
posted
we?
publicly, and I can also send that to you if you needed to.
Yes, please.
Okay, great.
Yeah.
Awesome.
All right, Shauna, you have your hand up.
So thank you. So I've reviewed the guidance document and thank you for that. And still, Dee, I have your question about how we identify a member when reviewing, because the PERT codes don't follow, at least in I've worked with 5 PBMs. In the systems I've worked with, the PERT codes don't follow the member. I still don't know how a PA reviewer on the outpatient pharmacy side or retail pharmacy side, they don't go into MMIS. I don't know how to identify these members. So I'm still struggling with that, but it's also only been 24 hours. But if anybody has any guidance of how to utilize what's in the guidance document in day-to-day workflow, we're currently stumped.
Yeah, and I think this is a process that we're still developing. I think with the CCO reps, we will develop a process to identify folks who are potentially eligible, haven't enrolled yet, and need to get through that process, versus folks who are enrolled and just need to be using their perks for claims purposes. I know this is where the dichotomy is, and I acknowledge that it's still a little bit confusing. It's a new program, it hasn't even launched yet, but our goal within the WISHN program is to go through the CCO reps because I think they will be the ones identifying the steps that CCOs need to take depending on where they are in that process to get WISHN folks into the one system to get them enrolled into the program, if that makes sense. So sorry for the still to be determined, but I think that's where we are.
And that makes 100% sense. My only hesitancy is the CCO staff you're talking to would not understand the pharmacy systems without a doubt. And I don't think they understand the UM systems. So they don't utilize the data to look at prior authorizations. So just be wary in that those folks don't understand what we do day to day. But we can work with them as well.
Got it. Absolutely. go ahead.
That's okay. Go on.
Yeah, if you could have your CCO representative, whoever you're working with, contact me. I'm happy to take in this comment. It's very, very important feedback. That way I can work on fixing this area that's still a little bit gray.
Great. Thank you very much.
Absolutely.
And
I
I
will
can.
put
Oh, go
I will
on.
put
You're going
my
to put.
email in the chat for folks who would like to follow up with me directly. That way we can continue this conversation outside of this forum.
Thank you, Max. I'll go to Mark, and then we'll probably need to move on to our next topic. I have a couple thoughts I wanted to share about fee for service first, too. But Mark, what's your question or comment?
Yeah, thanks, Dee. So just a question, particularly focus only on the pharmacy side of things. Mechanistically, is this essentially going to be like expanding the EP SDT type benefits to patients who are above the 21-year-old range? And if so, how does this program intersect once in 2027 the line placement disappears for pharmacy benefits?
Yeah. So yes, practically what it means is some individuals who are Wycian will continue getting EPSDT through their through age 25, so it would cut off at 26. We have developed a whole system with perks that would recognize Wycian um, and continue administering EPSDT for that period once they're enrolled. Obviously, this is a waiver program. We're expecting it to continue past that period, although please do not quote me on this. So for whatever happens after 2027, I would say subject to funding availability and to be determined, but we're cautiously confident that we will be able to implement through that age bracket, 19 through 25 up to 26 is the cutoff, and will be implemented as such. I hope this at least partially answers your question.
I think that's a good start. And then I had a couple thoughts, and then Roger, I'll include you, but we will need to move on. I guess EPSDT consideration in the pharmacy world goes a little bit beyond just quote unquote just the prioritized list. There are some other things that will continue to come up. For instance, optional benefits that Oregon hasn't chosen to add to our state plan. The biggest one that I can think of right now, and I think it was the Derm team who mentioned this, was weight loss, drugs for weight loss. So currently we do through EPSDT consider coverage of drugs for weight loss for people under 21. That's something that would continue even without because that's not a prioritized list thing. That is a state plan thing. So similarly, yeah, there could be similar things like that that are not based on the prioritized list, but still come up through EPSDT.
Correct. And that's the point. If folks are Wycian and used to get those treatments as a youth, they would likely get access to those benefits slash treatments up to their 26th birthday.
Yeah. But that was a good, I mean,
regardless of the prioritized list. Yeah.
Yeah, so it was a great question, Mark, and a good segue between those first two presentations. Roger has withdrawn his hand. I think he was probably going to, I stole his thunder. I think he was probably going to talk about the very thing that I just mentioned. But I will pass it on to Kelly to continue on. Thank you so much, Max. And I will share whatever you have to share. I will get it out to everybody.
Thank you, everyone.
Yeah, thank you, Max. That was great. I learned a lot. All right. So I'm going to get started. I'm going to share my screen, and I'm here to tell you about something more new that's happening. Okay. So I'm going to talk about Medicaid expansion in carceral settings, and I'm here with my colleague, Caitlin Payne. Caitlin's going to help keep me honest on some of the pieces. that we are going to talk about today. And I am also a licensed pharmacist in Oregon. So when someone earlier was shouting out pharmacists and that they do a lot, I appreciated that. Okay, so for today, I'm going to go over something called the Federal Consolidated Appropriations Act of 2023, or the FCAA. So we're going to review it and why it's relevant to the 1115 waiver, and the 1115 reentry demonstration waiver is what we're talking about when we're talking about the waiver in this context with carceral settings and Medicaid expansion into carceral settings. We want to review the differences between the FCAA and the 1115 waiver and their similarities to get a better understanding. And then also, we're going to focus in on some of the 1115 reentry demonstration minimum required services. And there are 3 of them, and 2 of them are pharmacy related. So want to have a higher focus on those things that are likely going to be impacting you all and your work. So for some background, we're expanding Medicaid into carceral settings. Oregon's expansion of Medicaid into incarcerated and recently incarcerated individuals aims to increase positive health and social outcomes. Currently, incarcerated and recently incarcerated individuals do not have Medicaid. When they become incarcerated, people lose Medicaid access due to federal law. There's like the federal inmate exclusion policy, so they do not do federal funding for individuals once they are incarcerated. So upon release from carceral facilities, individuals often experience a coverage gap as well, even if they, release and then immediately request. There's some processing time that happens, and that's a difficult transition period for many folks. So these gaps in coverage lead to difficulty in access to healthcare and vital services. And then another main focus of the waiver itself is to also reduce hospitalizations, death in the near term all-cause death in the near term post-release, and also overdose-related deaths in the near term post-release. So looking to the future, we are extending limited Medicaid eligibility in carceral settings, and we're hoping that it will achieve several things, including closing a coverage gap for these folks, creating progress toward a healthier Oregon, and proactively reducing health equity gaps in Oregon, as well as reducing social and financial costs related to recidivism and other negative outcomes. So the 2 new expansion efforts, as I mentioned, are the Federal Consolidated Appropriations Act, or FCAA, and then the Medicaid 1115 waiver, also known as the reentry demonstration. So the Federal Consolidated Appropriations Act creates requirements to expand Medicaid coverage to a subset of people who are or were formerly incarcerated, and it's focused on youth who are incarcerated. It is mandatory for all states, so it's not just Oregon. It requires that Medicaid enrollment be offered 30 days before release to youth under age 21 and former foster care youth up to age 26. It also includes certain Medicaid services like targeted case management, medical, behavioral, dental screenings, and those EPSDT services. And then the 1115 reentry demonstration waiver is kind of an expansion on top of the FCAA. So it builds on it, and the hope is for it to provide a method for carceral facilities, also referred to as CFs in my presentation, because it's kind of a mouthful, to build and pay for systems to offer new services. It adds, in addition to the eligible youth, also adults who are incarcerated be offered Medicaid enrollment 90 days before release. So if you would remember that FCAA was 30 days before release, this is youth and adults 90 days before release. It includes Medicaid services like medication-assisted treatment, or MAT, for substance use disorders, care coordination, and 30 days of pharmacy medications in hand at release, as well as medication administration. It becomes effective January 1, 2026, and to be eligible, a correctional facility must opt in to participate. And capacity building funds are available to prepare facilities for implementation. Some key differences here is that not all, so while all states are required to do the FCAA, not all states got an approved 1115 reentry demonstration waiver. So not all states will be doing this. The correctional facilities have to opt in to provide a minimum set of services in order to participate in the 1115 reentry demonstration waiver. And the FCAA does not offer correctional facilities capacity building funds, but the reentry demonstration does. So in order to get those funds, they do have to commit to offering the 3 minimum required services that we will talk about. So here is a visual. So we have the FCAA, the required targeted case management, comprehensive needs assessments, medical, behavioral, and dental screening and diagnostic services. And then outside of that, we have the building on that, the 1115 waiver, which includes family planning services, coming up with a person-centered care plan, behavioral and physical health needs, including medication-assisted treatment or MAT, substance use disorder services, other diagnostic treatment and prevention services, as well as medication and pharmacy, including pharmacy in hand at release and medication management. So as you'll see, those asterisk services of targeted case management, medication-assisted treatment, and pharmacy in hand at release are those 3 minimum required services that correctional facilities will have to provide in order to be opting into the 1115 waiver. Otherwise, they would just be mandated to provide the FCAA services. And then I'll have Caitlin add anything that I missed here if Caitlin's on.
I'm here. Yeah. I think the only thing I want to highlight is one of the differences between the 2 programs is the FCAA, like Kelly said, is like a limited set of benefits, and it's only for post-adjudicated youth up to age 21 and former foster care youth up to age 26. And so it really is a very specific group of young people that it is intended to serve. And then, like she said, just reiterating that it is mandatory, and that both in Oregon are intended to go live no earlier than January of 2026.
Yes, excellent. So now we will focus in on some of those pharmacy specific pieces. But first, I want to kind of walk you through a timeline of what it might look like for someone to enter a correctional facility and exit it. So right now, this is kind of like a little timeline. In red, we have enter the carceral system and exit the carceral system. So someone's entering the carceral system, they go through an intake process. What's included there may vary. And then closer to when they're exiting the carceral system, some release planning might take place. They might be released with a day's supply of medications. They might not. It might depend on certain criteria, like if they have a day's supply left, if it's in packaging that the individual is able to take with them for themselves to administer, etc. So then they would exit the carceral system. So under this kind of a model, I just kind of want to highlight who's paying here. So who's paying for, and what I'm talking about is the healthcare. So before they enter the carceral system, unknown, might have many, other different insurance. But while they're in the correctional facility, usually it's coming from the correctional facility healthcare budget because of the federal inmate exclusion policy, where there is not federal funding that goes towards their healthcare. And then once they exit the carceral system, they could become Medicaid eligible or, have third-party coverage again. But it's for Medicaid, especially, it's not allowed currently while they're in the correctional facility. And then who's providing the services? So, unknown might vary before they enter the carceral system. And then while they're in the carceral system, the correctional facility's healthcare model, that might be, they might have providers that come in to provide the care. They might have providers that they directly employ. It varies across the state. So the correctional facility healthcare model is providing those services. And then once they release, it's their post-release provider. So that's the current state, what it looks like now. And then the future state that we're working toward is that they would enter the carceral system. Their intake includes substance use disorder screening. If needed, they get connected to have a clinical assessment and connected to medication-assisted treatment if appropriate. And then at that 90 days, so this is under if a facility opts in to do the waiver, at that 90-day point, they're going to start pre-release planning and do care coordination with those post-release providers and the different services that they need. And then at release, a 30-day supply in hand of medications. And to be clear, it's not just a prescription. It's a 30-day supply. And then they would exit the correctional facility. And the main difference here for who is paying, it's still the correctional facility healthcare budget until that 90 days. Then for services that are Medicaid eligible, that Medicaid would be paying. And then they would be able to continue on with Medicaid once they release. So that the main goal here is that when someone's experiencing a transition out of the correctional facility, they're not also experiencing a transition with their care. We're trying to make sure that that's happening more seamlessly prior to their release. And then again, who's providing the services? It would be the correctional facility healthcare model while they are in the correctional facility. And then once they release, it could be their post-release provider or whatever plan they have. So I'm going to zoom in here on this 30-day supply in hand because I think that's an important piece I'd like to highlight today. So, oh, that was a fun zoom. So 30 days of medication in hand at release. What does this mean? It means correctional facilities are required to supply at least a 30-day supply upon release as clinically appropriate. Correctional facilities are allowed to provide more than a 30-day supply, but may only provide less than a 30-day supply when documented as clinically appropriate. So examples, birth control, maybe if they'd like to pay for more than a 30-day supply and it's available, they're welcome to provide them with more. Or for things like antibiotic courses, if you have a 7-day antibiotic course, it's not clinically appropriate to provide a 7-day supply of antibiotics. You would just supply the 7-day supply. Or other things like substance use disorder medications, if the provider feels it's clinically appropriate to limit the amount to less than a 30-day supply, then that is covered under what is deemed clinically appropriate for the medication and what it's being used to treat. So zooming in on our major activity timeline. So the person is in the correctional facilities, then we hit 90 days, then that pre-release planning starts, and we have that 30 days at release before they exit the carceral system. And then I have highlighted here who's paying for pharmacy. So prior to the 90 days, it would be the correctional facility. And then within that 90 days, it would be the CCO that they're on, or, fee for service, whatever care coordination they have selected or they're enrolled in while they're in custody. And then that 30-day supply at release and on is covered by their post-release CCO or care coordinator. So the key point here is that the post-release CCO or fee for service or care coordinator must be the entity billed for the 30-day supply of medications at release. And it cannot occur prior to their release date. Or prior to when their release date is known. I'm sorry, I will update that. So we're still working with correctional facilities regarding submitting release date information because a lot of different factors impact how timely that information is received, and it would be difficult to know when to start coordinating those medications and things like that if we don't know when they're releasing. And this also varies by which correctional facility type someone's in. I know we have here like a 90-day view, but there's also correctional facilities like jails where someone is not in the correctional facility for a period of more than 90 days. They might be there for less than 90 days. So there's just different models and it looks different based on the different correctional facility type that someone's in. So another thing that we anticipate might be an issue is the correctional facility formulary and CCO preferred drug list differences. So what the CCO covers or prefers on their drug list may not be a medication that the correctional facility can get from their pharmacy supplier. like I've said previously, the correctional facility is the one paying for medications or their care a lot of the time, because insurance isn't usually used. So they have agreements with their pharmacy suppliers to pay for medications at cost. They might choose to have different formularies or medications that they use based on what the cost is to the correctional facility to pay for it. And then that, medication or formulary drug that they use might not match with the preferred drug list that the CCO that the person has while they're in custody. So as you can see, it's, there's kind of quite a bit of potential pain points that we're anticipating. So another pain point is the correctional facility and future CCO. So what the CCO covers or prefers on their drug list might not be a medication that the correctional facility can get from their medications at release supplier. So that's another good point to bring up, is that the pharmacy model that the correctional facility uses, they might use like a mail order pharmacy. There's many like large national pharmacies like Diamond Pharmacy or CorrectRx for the medications that they have in packaging that they're administering to people. However, when they need to get someone medications at release, they might be using their local community pharmacies or partners like a Rite Aid or a Walgreens, or I think I saw like a corner pharmacy or something like that. And that is, and sometimes due to the fact that those pharmacies can provide the packaging and the labeling required for, like retail dispensing of pharmacy to patients, and they wouldn't be able to dispense like a bubble card of medications to someone. So there's also some differences there. And like, if a CCO has a certain preferred pharmacy or pharmacy chain that they partner with, we can anticipate there might be some pain points there as well. And then another pain point that we're anticipating is timing and quantity. So needing to have 30 days at release, and that person might have X amount left on their prescription, or they just filled it, 10 days ago, but, now they only have 20 pills left, and we're looking to give them a 30-day supply. And another place where that's kind of an issue is for high cost medications, devices like inhalers, other things like insulin, where you can't dispense like half an insulin pen or half an inhaler. And you would kind of have to decide if you would be willing to pay for it again in that shorter period of time in order for the person who's releasing to have a more seamless transition of care, so they aren't having to worry about how to get their medications in that near term post release, and they're not at risk of having whatever condition they're dealing with decompensate or put them at risk for other health issues. So zooming back out, for some discussion points, I know that was a lot of information. I just kind of want to see from the group, what challenges do you see with being able to seamlessly cover the medications a person was receiving while in custody to ensure continuity of treatment? And this could include removing barriers to refill too soon rejections, PAs for non-formulary meds, or any other anticipated barriers to filling meds that they receive while they're in custody. And then I'll just do all the questions, and then we can see what the group has to say. So how would you propose being able to meet the 30-day RX in hand requirement, like preferred pharmacy restrictions that we talked about, and again, like refill too soon, PAs, or maybe specialty billing requirements for certain medications like brown bagging or white bagging? And what challenges do you see regarding medication-assisted treatment medications for substance use disorder? I know we didn't talk a ton about that. We kind of focused on the 30-day supply at release. But I know that there's some specialty billing requirements for some injectable medications on some plans or coverage plans for pharmacy. And what are thoughts on maybe removing those barriers, or any creative solutions that the group has?
I'm on mute. Okay, great. Thank you for the presentation, Mark. Go for it.
Yeah, thank you. So just to clarify, obviously the CCOs would be responsible for the 30-day RX in hand, but you're saying also this will require the CCOs to cover the medications while the person's incarcerated. That's your slide?
Yep, yeah, and I did have, let me go back. I did have
Yeah.
it, where it's like
And
the
then,
CCO while in custody and then the post-release CCO. They may be the same. However, there's a lot of times where people are releasing to communities that are not the same community that the CCO is in. So there is a potential for a transition there as well.
Yeah, and then the pharmacies that they're being utilized while they're in custody, are those pharmacies DMAP enrolled and providing currently pharmacy coverage consistent with those regulations?
So we are doing like a landscape assessment where we're trying to get information from all of the correctional facilities on, what pharmacy partners you have, what pharmacies you use. The two big ones that I mentioned, we did check and they are Medicaid enrolled, but I can't guarantee that for all of the pharmacy models. That would, if they are to opt in, that would be like some technical assistance we would offer the correctional facility, that if you want to keep working with this pharmacy, in order to get reimbursement, they need to be enrolled. But we need to know what's going on first.
Yeah,
thanks, Mark. Norm.
Yes, I'm just curious on your slide there where it says CCOs while in custody. What is the time frame there? Is it they can be in custody for, I'm sorry if I missed it in your slide, for a certain amount of days, certain amount of months? Is that
Yeah.
what? Okay.
So it's only 90 days.
90
Sorry,
days while in
I should
custody.
have
Okay.
carried that 90 days over. So you're only covering them in that 90-day period.
And then when they go to post-release, they could go to another CCO. So would transition of care not apply here then? Because we also have a transition of care policy already in place for this. So they wouldn't apply to the transition of care policies that we have in place, right?
Can you tell me your thinking on that?
Well, we apply when a member goes from one CCO to another CCO, we are the receiving CCO is obligated to fill what the member has been provided previously. There are some limitations, but what I'm seeing is if that is the case, wouldn't there be some kind of confusion? I'm just seeing like there's a transition of care and then there's this incarceration process. I'm not sure if our systems can distinguish is what I'm trying to figure out if they come from another CCO to us. And I was wondering, I'm not trying to dump this or say this should be all on one, but have we thought of possibly having this process go through fee for service first and then members to when they're ready to go to a CCO?
Yeah, so we are still working on like our fee for service CCO model because, as you can tell, where I have here like the CCO while in custody and the post-release CCO and that being a transition, we are still working that out, so it's still kind of an open question. So I can't say where they are on their decision in that, but I will definitely bring that back if you think that if you and the group think that might be a good option to pursue.
Well, I think from the member perspective, if they're from one CCO, they're getting their medication, then they have to go to another CCO. There might be some confusion. There's some pharmacies that are not in network for that one, and there are in network for the other ones. I just feel that there might be a barrier there.
Great
Thank
feedback.
All right, we'll have, I think, time for just one more. I think I'll just, we can skip the critical access pharmacy follow-up, if that's okay with you, Shauna. And I guess quickly, is there public testimony or public? Okay, no. All right. So I think we will carry this on up to 11 then. Tiffany, you took your hand down. You can put it back up if you'd like, and you can speak now.
So I think I was just piggybacking on what Norm said. I think another consideration is halfway houses and sober living situations. A lot of times we've experienced in the incarceral setting, they're the best chance for success tends to be the sober living situations and things like that. And we often place them very far out of the CCO. So I think that's just another thing that may be leaning towards maybe fee for service, providing the service, so that initial coordination and transition gives them more options. Because I know network adequacy for beds and places like this is nowhere near where any of us wants it to be. And we don't want providing this extra service to somehow be a barrier to them going where they have a bed, right?
Thank you, Tiffany. More input to take back, it sounds like.
Yes,
For
for
a
sure.
halfway house, is that still a carceral setting? Or are they out?
A lot of times they're out.
Okay.
And it's like, and then they're just community-based organizations, which through our health-related needs expansion, we're doing a lot more of. And I'm thinking of coordinating it with those services and things like that. A lot of them
more of a
are
landing
no
pad
longer.
than a pre-release.
Yes.
Okay.
Helen, in your chat, you say, could there be a small group to talk through options that make sense?
Options that make sense in terms of how to handle that that before 90 days with regarding pharmacy specifically.
Helen, are you able to hop off mute and maybe not? I can try to. Oh, there we go. Oh, I can also reach out to Helen. Anyone, if you have comments or questions, I can send them on to Kelly and
Yeah,
Caitlin.
for sure.
There's just a ton of work happening. I know the big focus now is trying to survey the landscape and see what all the facilities are doing. And I had the privilege to review what the survey looks like. Very detailed questions. I think a pharmacist might have been involved, and that was very thoughtful. I was impressed. I think it would be
Hey,
helpful
sorry,
to
I just Helen, really quick. I know we're at the end. I thought it was really good information presented. I just, I think there's a opportunity to really get, a small group together to talk about what are the options, right? Because we don't want to make it harder, right, by going, into one CCO and out to quickly, like within 90 days. I think the multiple transitions will be hard. So if there's a way to make sure there's like one transition, that the first 90 days be as seamless as possible. And then you kind of enter the real world of how Medicaid works. And I mean, into the choose your CCO, right? Which is something that they have a choice, right? So I think that would be more successful. So I like the idea. That may not be the preferred way that the state wants to do it, and I understand that, or there may be a legal reason we can't do it that way. But it seems like we should think through what are the options, right, to make it as seamless as possible, given the reality of how people are placed, and the fact that once you're outside of incarceration, it's about working toward being successful, right? That's what the goal is. And I don't know, it just seems like we got to think this one all the way through end to end. And I think your
Yeah.
presentation helps us all do that. So thank you for that.
Yeah. And then just out of curiosity, are you thinking of like the pharmacy benefit specifically just being kind of in a certain way? Or I think the reason why they were maybe as like a total policy, not wanting to only do fee for service and then CCO, so that we could, leverage the relationships that the CCO has and their case management ability. So that, a lot of considerations. I can definitely ask Dee to come back for your next meeting. Because we
will
get
not turn
our
you down.
yeah, we get our like landscape assessment results back middle of October, so we're gonna have a better idea of probably everything. So
yeah,
let's do that.
Yeah, that makes sense. Yeah. Thank you.
And we do. It's not until the next. I know it's not actually really that much time, but it's not till next year, like 2026. So.
True. There are some states that have gone ahead of us. So we will bring this back. We are at time. I think this has been a while since we've gone all the way up to the end. So thank you so much. Really appreciate those presentations and the engagement from everyone. I promise this was a good group with engaged
I think Dee has frozen. Yeah, on my part. Okay.
Your batteries ran out.
Okay. So
Thank
I
you,
guess
everybody.
we will end.
Thanks, everyone.
Thanks.
Thank you.
Bye-bye.
Thank you.